different GI societies, and he's published already 10 journal articles and 2 chapters. He's given a number of presentations. Among them, this is not his first rodeo. This is the second time he's given grand rounds for the Department of Medicine, and we appreciate that. And I counted 14 national presentations as well. He's an active teacher. He is a founder and director of the Guiding Principles in Gastroenterology, the core curriculum for GI Fellows. He's, of course, co-director for the Gastroenterology and Hepatology Pathophysiology teaching block for the second-year medical students. He's also been active in educating physician's assistants, as well as giving at least one talk for the community at the Community Learning Center at our Digestive Health Center. He's been an active citizen and volunteer, earlier on teaching in Patient Doctrine Society and also volunteering at the Grace Episcopal Church Free Clinic. And he's involved in a number of activities and committees here in the department and division. Among them, he's Director of Graduate Education for the Division of Gastroenterology and Hepatology. He's on the Fellowship Committee for the division as well as the Research Committee. And he is the co-founder of the Pediatric to Adult Inflammatory Bowel Disease Transition Clinic, which really is the basis for his talk today. Today, Dr. Grimes is giving grand rounds entitled Growing Pains, Transition from Pediatric to Adult Clinics in Patients with Inflammatory Bowel Disease. Please join me in welcoming Dr. Grimes.
Thank you very much. I should have had him write a letter to Santa for me. It might have been a little better Christmas this year. So I'm going to talk about our transition of care clinic in patients with inflammatory bowel disease, a co-venture here with Pediatrics, and thank you for having me this year. I want to start off with a case that kind of illustrates some of the main points that I'm going to talk about today. So younger patients, someone we don't always see, but again, it illustrates the points of the talk. A 15-year-old develops right lower quadrant pain. They've got loose bloody stools while they're in school. They've got some concomitant features that make you a little bit worried that this is something more than just garden variety illness. They've got low-grade fever. They're starting to have some weight loss of 5 to 10 pounds, and they've got some joint pains, especially worse in the morning. They're a little bit puffy. Eventually, parents bring them to the emergency department where they, of course, get a CAT scan, which is significant for ileitis and perianal inflammation. So there's a concern here for inflammatory bowel disease. Stool studies are collected as these things haven't been done. They started the patient empirically on antibiotics, and then was set up for a colonoscopy. And this is a look at the patient's small bowel. And for those of you who don't spend every part of their day looking at someone's small intestine, this is not normal. So this is red, it's inflamed, it's irritated, it's ulcerated. Biopsies are taken, they show granulomas, signs of chronic architectural distortion, so consistent with a diagnosis of Crohn's disease. So a young patient with some severe markers of Crohn's disease. And I would advocate for you that this talk, so everyone who takes care of patients is going to see someone like this. So patients with chronic disease, it's important that they receive uninterrupted care. And this goes across multiple specialties. So diabetes, cystic fibrosis, and those, the pulmonologists are really the ones at the forefront of the transition process. Asthma, congenital heart disease for our cardiologists, patients who are young and undergo liver transplants, for chronic liver disease, to really anyone with a chronic illness. These patients are going to need uninterrupted care for their chronic disease to have better outcomes. So to get to where we want to go today, I'm going to talk about the epidemiology of inflammatory bowel disease, talk about the natural history and why it's important for patients who are treated to receive chronic medications and to receive uninterrupted care, talk a little bit about the differences in patients who are diagnosed when they're younger versus older. Then the meat of the talk about the transition process, why that's important, and what we've done here at UW in conjunction with the pediatric GI folks. So as you know, inflammatory bowel disease is common. It affects almost 1.5 million Americans at last count. It's predominantly a disease of younger people with a peak onset of 15 to 30, though there's a second peak in the 50s and 60s. And we really see people who are diagnosed anywhere from age 5 all the way to 75. So we see the ages run the gamut. And it's becoming more common, not only in our society, but across the world as societies move to a more modern culture. And this is in part due to changes in our diet, increased use of antibiotics, which leads to changes in the intestinal microbiome and the intestinal colonization. All those microbiome is changing over time, likely leading to an increased incidence of inflammatory bowel disease. There's some geographical concerns as well, as it's more common in Northern Europe, North America, farther away from the equator, it tends to be a little more common as well. So a graphical representation of that peak, really showing that the younger patients here are where we're going to see the vast majority of our diagnoses. But again, we see patients diagnosed all the way up in their 70s who don't really have any features that you would think that they have had this before. Second peak in the 50s and 60s. So anything with bloody diarrhea, abdominal pain, for about a month or so, we start bringing inflammatory bowel disease to the forefront, no matter the age. A brief about pathogenesis. I talked a little bit more about this in depth last time. This first bullet point really is the key slide to, or key points to the pathogenesis of inflammatory bowel disease. So there's an inflammatory response, and it's inappropriate. Not only should it not have started, or if the inflammation did start, we're unable to regulate it appropriately. It's thought to be a response to those intestinal microbes, those billions, trillions of bacteria in the microbiome that gain access to the deeper layers of the mucosa in a genetically susceptible host and start an inflammatory response that just can't be controlled. So increased permeability of the mucosal epithelial cells is thought to be an inciting event, this so-called leaky gut. There's some evidence that this happens in everyone, some evidence that it happens just in a unique group. But increased permeability starting the immune responses is really common. The epithelial defense mechanisms, the zonulins, are impaired, and this leads to increased inflammation, which we're not able to turn off. In a group of patients, there's dysfunction of CD4 positive T cell subgroups, and the unregulated inflammation leads to increased tumor necrosis factor and release of cytokines, and we're just unable to stop. So in this first bullet point, if you take away anything from the pathogenesis, it's this inappropriate inflammatory response to intestinal microbes in a genetically susceptible host. For those visual learners, this is an easier kind of a bubble graph way to look at it. So genetic susceptibility, not 2 genes. They've done GWAS studies, which have shown changes throughout defense mechanisms. Environmental factors also play a role. Changes in the microbial flora, changes in the microbiome due to diet, antibiotic use, changes in intestinal colonization. Location, I mentioned it tends to be more common in the northern hemispheres, all leading to this 1 or 2 hits, probably 3 hits, that lead to an immune response that is inappropriate, it's out of control, and chronic inflammation. Briefly, I want to touch about the differences between Crohn's disease and ulcerative colitis. We're going to focus more on Crohn's disease today because it's more common in the pediatric and adolescents, and it tends to have a more severe phenotype. They tend to be on medications that do require uninterrupted care. Crohn's disease itself, as you know, tends to involve the small intestine, end of the small intestine called the ileum, as well as the colon. But it tends to be really patchy, so any area of intestine can be involved, anywhere from the mouth to the anus. So you can have a patch in the small intestine, a patch in the colon, or a patch in the stomach. It's discontinuous, pathognomonic on pathology or granulomas, and the chronicity of the inflammation over time leads to narrowing, strictures, small bowel obstructions, penetrating disease, which we call fistulae, abnormal communications between two body tubes that are not normally connected. And it's all because of this transmural inflammation. So if you think about the colon or the intestine as a pipe with multiple layers, transmural inflammation means it involves all 3 of those, or all of the deep layers. So there's deep inflammation. Contrasting that with ulcerative colitis, another common type of inflammatory bowel disease, involves the rectum and moves forward in a proximal continuous manner. So it can involve the sigmoid colon, can involve the transverse colon, but moves forward in a continuous manner. Started in the rectum, instead of involving all those deep layers, only involves the mucosa. So you tend to not get some of the complications of strictures and fistula formation. Again, for visual learners such as myself, this is another way to look at it. So Crohn's disease on your left, skip lesions throughout can really involve any area of the intestine. Ulcerative colitis starting in the rectum, moving forward in a continuous manner. So we're focusing mainly on Crohn's disease today for the reasons we talked about. Its natural history, most patients there tend to be three types of, or phenotypes with Crohn's disease. Inflammatory type, where the mucosa is involved, causing bloody diarrhea. Stricturing disease, where patients tend to get narrowing of their colon or small intestine leading to bowel obstructions. And then penetrating disease, which are the fistula. This graph shows the natural history of Crohn's disease over time. Most patients, about 80%, start with an inflammatory phenotype, and the chronic inflammation then leads to changes, including stricturing disease and penetrating disease. This graph's a little confusing in that the y-axis here is the inflammatory component, but everything adds up to 100. So as the inflammatory component goes down, penetrating and stricturing phenotype rises to the forefront. So we believe if we're able to arrest this inflammation when the patients are younger, we can stop these downstream complications. And that's another reason why they need uninterrupted care. So this is a Netter diagram showing some of those complications with Crohn's disease. On the left here, this is a small bowel, and you can see the already thickened small bowel, all the deep layers, all the transmural inflammation that's involved. There's an abnormal communication here, small bowel to small bowel, so fistula, they already have penetrating disease. Over here on the right, again, a small bowel with a fistula to the colon, and a fistula either to the bowel or to the bladder or in the vagina with stool passage through out. And you can see that that would be very disconcerting for patients. Again, long-term complications that require chronic medications. So we're going to focus on adolescents today because this is a really at-risk group. So these patients tend to have the worst disease, and they're going to have it for the rest of their lives. This is a chronic autoimmune disease. So there's something we need to think about in this special population. Everyone who has kids know that adolescents are, they're all different, they're all special. But younger patients who have this disease are at increased risk of complications. Not only because they're going to have the disease for the rest of their life, you saw that natural history graph, they're much more at risk for those complications. This is a time of development for them that can stunt their growth moving forward. They're not very mature, sometimes it's very difficult for them not only to go to the doctor, but to get appropriate blood tests, to take their medications appropriately. This leads to compliance difficulties. We'll go over some data that shows that they actually have more complicated disease, worse disease when they're diagnosed at a younger age. So pediatric inflammatory bowel disease, those diagnosed when they are younger, comprises about 25% of initial diagnoses. These patients are all going to show up in the adult world. It's got a rise in prevalence. You can see this graph from 91 to 96, 97 to 2002, there's growth. 2.4 out of 100,000 people in the pediatric world have inflammatory bowel disease, more likely to be Crohn's. Then ulcerative colitis, so more likely to have that more severe phenotype, and it's more likely to be complicated, not just the inflammatory disease, but the narrowings, the fistula, the abnormal communications. They tend to have much worse disease. So this is a paper that came out about a year and a half ago now in Gut, looking at patients and the age of when they were diagnosed and how diverse their disease was. They looked at quartiles, those less than 17 to 39, 40 to 59, and those over 60 when they were diagnosed. And this lighter graph here, L1 disease, that's only ileal disease. L2 here in the green, that is colonic disease. And L3 here, that is ileocolonic disease. So the L3 tends to be a more extensive, more diverse, potentially more severe phenotype of disease. And you can see when you're diagnosed at a younger age, less than 17, compared to over 60, much likely to have a more severe phenotype. And that meant statistical significance. But you can also see a trend, being diagnosed younger tend to have more severe involvement in the other quartiles as well. There's a similar graph for ulcerative colitis in that if you're diagnosed younger, again, you're more likely to have more severe disease. So again, you may need our strongest medications and require them for the rest of your life. A paper from a little bit older, but they followed a cohort of patients with inflammatory bowel disease, mostly Crohn's disease, of 650 patients to really assess their natural history. And they followed them for a long time, 7 years a median. Thought that was a pretty good follow-up. And the patients were more likely, about a third of patients had upper GI involvement, so involvement of their stomach, esophagus, mouth. We don't see that as much in adults, so again, a marker of more complicated disease. They were more likely to have extraintestinal manifestations, arthritis, ankylosing spondylitis, where they may show up in rheumatology. You could have erythema nodosum, pyoderma gangrenosum, or uveitis. And they also had risk of steroid dependence. So a quarter of these patients are on chronic prednisone. And you can imagine what that can do when you're young. It can stunt your growth, increased risk of osteoporosis, Moon's disease, adrenal insufficiency, long-term complications, not only from the disease, but from the medications that they're on. This is a graph showing that we looked before at the overall natural history of patients with Crohn's disease, and this looks more specifically at those who are younger. Again, most patients start with that inflammatory phenotype, about 70%, and over time develop more of a stricturing or narrowing phenotype, where they are at risk for small bowel obstructions and at risk for complications such as fistula. Again, our belief is that if we arrest this disease with our best medications, that we can slow down this trend. So these patients really do deserve our best medications and uninterrupted care. So following this group out a little bit further, almost half required surgery at some point. The 1-year risk was about 7%, 3-year risk, 1 out of 5. And by 5 years, a third of patients had surgery. And you can see going out, 50% mark is at about 10 years. So again, if we're able to stop the disease, arrest it with our best medications as they move not only throughout the pediatric world, but into the adult medicine, we can change the natural history of this disease, and maybe we don't see them as much in the hospital and requiring surgery for this really high-risk group. So I hope I've shown you that pediatric onset inflammatory bowel disease, focusing on Crohn's disease, is a high-risk group. They're at risk for complications. We think that they'll benefit the most from our best medications, our disease-modifying therapy, with our goals of taking that angry, nasty-looking ileum, making it look pretty normal, so mucosal healing. So what medications, what are our goals when we're treating these patients with medication? We want to induce, not only make them feel better, but also maintain remission. It's not just getting them better with steroids, it's making them feel better, stay, and improve their quality of life. We want to prevent those long-term complications, keep them out of the hospital, keep them from needing strictures, keep them from needing chronic prednisone, and reduce their surgery rate. So again, we're looking at taking that angry-looking colon and small bowel and making it look normal. Again, we believe this has the potential to change the natural history of the disease, decreasing hospitalizations, surgery, and long-term decrease in inflammation decreases the risk of colon cancer, which you know is associated with inflammatory bowel disease. So again, this is a colon, and again, for those of you who don't know what the inside of a colon looks like on a regular basis, this again is raw, it's irritated, it's angry, it's red. Imagine if this were on your skin. It's not something that would be very nice. So we want to take that angry-looking colon and make it look normal, and then try and keep it that way with the medications. Briefly, some of the medications that we have, some of these you're familiar with. So started in the 1960s, we were treating this with diet, which still is not really proven to work all that well. We still have steroids. They work when you need them, but they're not a medication that you want to be on long term because they have such severe side effects, which you're all aware of. 5-ASA agents, sulfasalazine, became in the 60s, and then we had azathioprine, mercaptopurine, more recently budesonide, methotrexate, TNF inhibitors, which are our best medications, like Remicade, which are dosed every 8 weeks, IV, Humira, Cimzia, and newer medications coming down the pipeline all the time. So I just briefly want you to know some of the medications that we're using to hope to prove to you that they have side effects and that they need uninterrupted care. So combination therapy is our best medication, so using a TNF inhibitor, something like Remicade, Humira, Cimzia, in combination with an immune modulator azathioprine, or captopril. We're always weighing better outcomes. So there are evidence studies that we'll briefly go over that show that patients on these medications do better versus the risk of side effects. When you're younger, the risk of side effects are not only acute, but long-term. We really want to make sure that our patients are going to benefit. And who does benefit? It tends to be the younger group. Those who are younger, so definitely less than 40. I think you can make a case based on things that we've seen, and what we're seeing is that if you're younger, you have markers of severe disease as well. Those with perianal disease, if you're already starting to get narrow, if you've already got fibrosis, you've already got strictures, you're more likely to have severe disease. If your disease extent is severe, if it's not just in one patch but all over with Crohn's disease, again, those are more likely to be pediatric patients. Or if you have ulcerative colitis, it tends to be all over. Need for early steroids. These patients, about a quarter of them are on chronic prednisone, so they're going to need early steroids. Another reason not to smoke, we want our medications to work and work well. Those patients tend to do better, and we want them to take our medications. Lower education level probably plays into that. Briefly, I won't go in depth on this, but this is a trial from a couple years ago, a little bit dated now, that shows that this combination therapy does tend to work the best. So they randomized patients to Remicade or infliximab alone, azathioprine alone, or the combination of the two drugs. And they found that patients on infliximab plus azathioprine had improved corticosteroid-free clinical remission at week 26, similar data at week 52. And not only did they feel better when they were in clinical remission, but objectively, things looked better. The mucosa looked better. So these are medications that are going to require them to be on long term. So again, increased rates of corticosteroid-free remission, mucosal healing at week 26, similar data at week 50. And this is likely in part due to lower rates of antibodies with infliximab due to azathioprine. So it's the combination of medications that may work better in these severe patients. There was a similar study for ulcerative colitis showing again that patients on combination therapy did better than either one alone. Now when we start these medications on younger patients, we have to think, this is the special group. They not only have severe disease, but there are other comorbidities that we need to be aware of. So when we're starting these medications on younger people, young adults, adolescents, we worry about hepatosplenic T-cell lymphoma. It's a special type, it's a type of non-Hodgkin's lymphoma, which is almost universally fatal. So there have been 36 published reports that I could find in review articles showed involving inflammatory bowel disease and hepatosplenic T-cell lymphoma. And 11 of those 36 patients were less than 20 when they were diagnosed. So they had been started on a younger age, more likely to be males. So we always worry about that when we start these medications, and we always talk to the patients and the families about them. Increased high-risk sexual behaviors in this younger group. Some of the medications are teratogenic, so they need to be aware of the side effects of the medications. We counsel them on that. We recommend they get HPV vaccines as well, as there's increased rates of cervical cancer in patients with inflammatory bowel disease. There's drug experimentation in this group, leading to side effects with the medications. They may not take their medications appropriately. And also in this group, mental health disorders are common. We'll go over that a little bit more in depth. That may also play a role in not only in taking the medications, but taking them appropriately. So, moving on to transition. So, I hope I've shown that young adults, adolescents have high rates of disease. They tend to need our strongest medications. Those medications have side effects, and that these medications need to be taken on a continuous basis for them to do well, to hopefully change the natural history of their disease, to decrease their rates of hospitalization and surgeries. So adolescents tend to have a more severe phenotype. They're likely to be on chronic medications because they're sick, because they tend to have a more severe phenotype. Hopefully it's not prednisone, and they have multiple comorbidities as well, including mental health disorders. They really do require uninterrupted care as they transition into the adulthood process. So if we're able to make their transition from a pediatric provider to an adult provider a little more seamless, so they don't get the medications interrupted and end up in the hospital, that's the goal of the transition process. So in my experience, what you find when you are an adolescent or a young adult, there's kind of two types. You've got, I'm dating myself a little bit here, but you've got your Zach Morris type on the left, you kind of got it all together, you kind of know what you're doing, you've got a plan for everything. You can handle pretty much anything that anyone throws at you. Like, yeah, I can make my blood tests, I can get my appointments. Not a problem. And then on your right, you've got your Napoleon Dynamite type. They're just kind of floating through adolescence. What things happen to them, they don't really make things happen. And so they need a lot of help. The goals of the transition process are to get those patients on that end of the spectrum to take a little more ownership of their health care. When I was reviewing this talk, I came across a patient quote which said when they were younger, when they were less than 15, it really wasn't their disease. It was their parents' disease. Parents made all the appointments. Parents made them take all the drugs. Parents made sure they had their labs. Even though they had some of the complications, the side effects really didn't feel like their disease until they moved on into the adulthood and they started to kind of take ownership of it. So the goal of the transition process is to make those patients take ownership of their disease. So transition of patients, as opposed to transfer, where they just show up at your doorstep to establish care, which you may not have met them before. Transition is the purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions from child-centered, the warm, fuzzy pediatric world to the cold, dark world of adult healthcare. I mean, it really is. Compared to pediatrics, they watch movies when they get their infusions, they're coddled, it's fantastic. So then they show up at our door, it's not quite as warm and fuzzy in the adult world. So trying to get them all in that place. With our goal is really to make them the best that they can be, not let their disease define them, but let their disease be a part of them, but not really slow them down. If they want to go to medical school, if they want to do whatever they want, their disease doesn't slow them down. So those are the goals. How does that happen? It's a slow process, and pediatrics does almost all of this. So it's a transition to self-management from more parent-centered management. This involves gradual changes. It's not a process that happens overnight or even in months. It's a years-long process. Changes in knowledge, attitudes, and behavior, which in that group tends to be difficult. So adolescents slowly assume responsibility for all aspects of their health care. They begin to understand that they need to take their labs, that they need to take their medications. They begin to understand insurance issues. They redefine their role to self-management of their condition. This is from an adolescent conference that came out, but their goals were that physicians who provide care to young people with health care should understand the rationale for transition, which is kind of what we're trying to go over today, have the knowledge and skills to facilitate that process, something that happens more in the pediatric world, but something we should be aware of, and know when transfer of care is indicated. It's not just when you turn 18. There's a maturity level that also goes along with that. So again, just to remind you, no matter where you practice, you're going to see these patients. So diabetes, cystic fibrosis, asthma, congenital heart disease, liver disease, really anyone with a chronic illness, these patients are going to be seen by us and cared by us. This transitional period tends to be a vulnerable time. There's not a lot of data on it, to be honest, but we'll go over some of it. A structured transition program may have a positive effect on clinical and psychosocial outcomes. Physician continuity is thought to be a protective factor against long-term side effects in young adults, lower hospitalizations due to better control of their disease. There's some data from liver transplants. So they look at 52 patients who were transferred. So these are patients who just showed up in the adult world. For a first visit, there was no kind of structured transition process. They found is that the adolescents and adults really didn't understand. They didn't know who to call. They were comfortable where they were before. Now they have to go to a new building. They have to actually make a call. The parents aren't doing it, so they weren't sure how to make their own appointments. They really didn't understand insurance issues, which I totally get. I don't totally understand insurance issues myself. It changes every year. So I think that is something that we can certainly work on. And they couldn't really manage their liver disease independently. They still needed help from their parents, even if they were away at college. And you can see how this could lead to worse outcomes. They're not taking their meds, they're not getting their labs, and they're not able to get side effects and stop them before they occur. So compared to adults, adolescents are against a high-risk population. They're more likely to be in the hospital over a 2-year period, They're more likely to be on biologic therapy, so our better medications. And as we all know, they're more likely to miss appointments. So if you've got a group of younger patients on your schedule, you may have a missed appointment that day. So our goals are to kind of slow this down and get the adolescents, make sure and let them know it's more important that they show up. And again, mental health disorders are common, and this is one of the cornerstones of our transition clinic. So about 20% or 1 out of 5 adolescents have an identifiable mental health disorder, which I don't think is shocking. So there's also multiple psychological stressors associated with young adulthood. It's so hard to be a young adult. Just ask them. There's time is taken. They can't handle themselves, can't handle their health care. Looking back now, it seems like a pretty ideal time. You don't have a lot of responsibilities, but they seem to be very frazzled, and it's difficult. They looked at 20 post-liver transplant patients and followed them out for a year, and they found that if you had increased scores on your mental health questionnaires, you're more likely to take your medications. And they monitored that not only by looking at whether you refilled your prescription, but they checked your Crohn levels, and patients were more likely to have a therapeutic level if they had overall better mental health questionnaires. So we're able to screen these patients, we can help them take their medications long term. Inflammatory bowel disease patients I feel like they're at a special risk for mental health disorders, in part due to the risk for body image distortion. Can you imagine being in college or high school and you've got incontinence throughout the day, you're having multiple bloody stools, if you're having tenesmus, you feel like you gotta go to the bathroom, you show up, there's nothing there. Patients are having diarrhea, they may have had surgeries, they may have an ileostomy in place, they may have scars on their belly, and they're on medications that they may have to take during school. And this could all separates them from their peers, leading to increased risk of body image distortion, mental health disorders. So switching gears to the clinic that has been started here at UW. So again, just to review, transfer of care is patients just kind of show up at your clinic to establish care versus the transition process. So we're preparing the adolescent for life as an adult, thought to improve continuity. They know who their adult providers are going to be. Differences in goals for pediatricians versus adult providers need to be explained a little bit to the patients, whether it's at that initial visit or later on. Pediatricians tend to be overall more clued in on growth and development. They don't want you to fall off that growth curve. Adult providers tend to look more at cancer surveillance, sexual function, long-term treatment of the disease. So again, a lot of cases are diagnosed when they're younger. They tend to have worse disease, and they really do require uninterrupted care. So how does this transition process work? So most of the heavy lifting here is done at the pediatric level. So when they're 16 or so, sometime around there, and they're a little mature, they're taught the importance of medication knowledge. What medications do you actually take? You'd be surprised. People don't know when you see this. In this very building all the time, patients show up in the ER, they have no idea what medications they're taking. It's in the system. So we want everyone to know kind of what medications they're taking. Know about their insurance, and really take ownership of their health care. We want them to make their own appointments, set up their own lab visits, refill their medications, and start to show up, at least in the clinic, on their own. Maybe the parents can be on the waiting room with them, but to take the visit on their own. So how does this occur? Again, this is a gradual process. This is not something that occurs in 1 or 2 visits. And again, pediatrics does most of the work here. So about a year before transition, they're taught how to make their own appointments. They're encouraged to make their own appointments. What works for you? Look at your schedule, try and make an appointment that seems appropriate. They refill their prescriptions. They call the clinic with questions. If laboratory tests are needed to get a refill of their medications, they're taught to arrange that, and to carry their insurance card. 6 months, so all this has kind of gone over again and again. About 6 months before the transition process, again, review the insurance situation, start to kind of firm up their post-high school plans. Are you going to get a job, stay locally? Does it make sense to you to have a GI physician here? Or are you going to move away? Are you going to go to college somewhere but still be home here? Then it would probably make sense for you to have a physician here, or are you going to go away? Your family's going to move. Do you really need to reestablish locally? And then 1 to 5 months before the transition clinic appointment, which I'll go over next, review the transition clinic, who's going to be there, the importance for that, review the medication schedules, the importance of taking the medications on time when they're supposed to be taken, again, review insurance information, and have clinic phone numbers available and with you. It's an easy thing to do now, just plug it into your cell phone. And then when you're 18, so as internal medicine providers, I like the patients to be 18 when I see them. At the Digestive Health Center, we're not supposed to see patients less than 18, so we want them to be at least around 18. And those who are mature, thought to be ready for transition, are referred over to the clinic. Importantly, we want their disease to be quiescent, so we want them to be in good control. When you're moving over, establishing a new provider, we don't want their disease to be flaring. This is not kind of a second opinion clinic to get you better. It's kind of a, I'm doing okay, I'm going to move on to the next step in care. So we have a group of people who are involved in the transition clinic. So Janice Singles is, Dr. Singles is a health psychologist. She screens all the patients for mental health disorders and talks with the family, and she also has a clinic at the Digestive Health Center, so can follow up the patients there. Dorota Walkiewicz is, she really took the lead on this clinic. She's a pediatric GI provider. And then myself also. So what we do is, we all three, plus Dr. Walkiewicz's nurse, Amanda Nadler, meet with the patient and parents. So one room, we all go in, we all say hello, and kind of explain the transition process to everyone. And then we move the parents to a separate room, so it's a little bit room intensive, so we require at least 2 rooms. And then we split up. So Dr. Singles will go and talk with the parents, see if there are any concerns about transition, review if there are any mental health needs that need to be taken care of or can be identified if the parents are worried about them moving on. And kind of making sure they take their medications. And Dr. Walkiewicz and I meet with the patient and again review their disease, kind of assess their readiness for transition. And we do that with some questions. The Mariski Adherence Scale is a scale that helps us see if patients are taking their medications appropriately, and we go over their disease-specific knowledge to actually know what their disease is, and again, screening for mental health and nutritional issues. So you don't have to know all this, but these are the questions that we ask them. And this was actually built into HealthLink by Epic. You just scroll to F2 and everything pops up. It goes really quick. And these are the questions that we go over with patients when they're by themselves. Some of them just whip through it. They know exactly what their diagnosis is, they know where it is. Others are a little bit slow. These are the things we want them to know. So we want to know what their diagnosis is, when were they diagnosed, what is involved. Have you only been treated here? Have you been treated elsewhere? If you're going to transition and show up, we're going to want to get those records, so it allows us to kind of get the jump on that. Have you been hospitalized before? And that's a marker of severity of disease. Have they had surgeries? Do they have special considerations that we need to take care of, nutritional? Have they had complications? What medications do they take? Do they actually know how to take them? Do they know that they need to take it every day or twice a day or 3 times a day? And we want them to know the side effects of the medications, the risks of cancer, the risks of bone marrow suppression, the risks of hepatitis. So they kind of know and take ownership of the medications. Importantly, we want to know what they've been on before. Did they stop it because there was an adverse effect, or just wasn't effective, or were they just not on it for a very long time? So you don't really know. So that's something you can go back to if you need to. Again, review insurance information. Do they know who to call? Can they kind of do this on their own? So that actually goes pretty quickly, and then we review their medication adherence. If you ever forget to take your medications, if you have problems remembering to take your medications, when you feel better, do you stop? Or if you take the medications, you have some side effects, do you sometimes not want to take them? All keying in on actually, do you take your medications? Which is important. So then we switch. So then Dr. Walkiewicz and I will go and talk with the parents and ask, see if they have any concerns, while Dr. Singles, the mental health provider, will talk to the patient, again, screening for mental health disorders. Then we all kind of meet in the hallway between, and we talk about them briefly. Are they ready for transition? Should they show up now? Are there any other appointments that they need? Mental health, nutrition. And then we all kind of come back, talk, again, 5 or 10 minutes, and either decide to move on to the adult world or stay in pediatrics for a little while. Most of the time the patients transition, I'll go over some of the data that we have that shows that. So really nice that PGI will then kind of wrap this up. So just like patients when they're discharged from the hospital get a discharge summary, they kind of provide a discharge summary about the patients. So patient XYZ diagnosed with Crohn's disease when they were 5 years old, and had these complications, been on these medications. Just kind of a nice wrap up, and that's a nice document to have when they show up on your doorstep, even though you already kind of know them. And if they need to go back to PHGI for a while, that's fine too. Eventually they're all going to show up. I mean, you can't stay with your pediatric provider forever. So it's a process, but eventually they all come. So we're still not done. The next visit with the patient is at the Digestive Health Center. And then to close that loop, we will have a teleconference over to pediatrics, to Dr. Wolkevich's office, and we'll meet with her, again, see if there are any questions, concerns, make sure the patients and parents are comfortable. Really trying to make them know that we're still all on the same page and helping to take care of their patients or the patient. If their mental health disorders were discovered and they need follow-up, that's also arranged at the Digestive Health Center, along with that nutritionist visit. We try to get this appointment scheduled within 6 to 8 weeks so we don't lose momentum, so that they're kind of ready for it. And until they show up to this appointment, they're still the realm of pediatrics. Even though I've seen them once before, they're still the pediatric patient. Anything comes up, flares of disease, refills of medications, they're still a pediatric patient. And I think that's important, and we'll go over a little bit more about that. I think it's important for the patients to know. So these are the barriers that we kind of identified before we started this clinic. So who's in charge of the patient? At this point, even at the transition clinic appointment and until they show up at the Digestive Health Center, in my mind, they're still a pediatric patient. They're still housed medically through pediatrics. And I think that's important for the patients. You don't want to change, at least personally, you don't want to change a lot of things on that first visit until you gain their trust. Location issues were difficult, so where are we going to actually have the clinic? Is it going to be in adult or at the Digestive Health Center here, or at the Children's Hospital? Children's Hospital seemed like an easy fit because, again, these patients are still medically homed at pediatrics, and they were able to accommodate space for us. But when there's barriers, geographical barriers, trying to find a place for everyone to meet can be difficult. Finding a time for multiple providers when they have free time or clinic time available could be an issue. Payment issues as well. So 2 physicians can't bill for the same visit. So again, these are pediatric patients, so they do the billing for the transition visit. I do the billing for the second visit. Again, that's a barrier that needs to be talked about. And then barriers for the patients and family. It's an initial visit. It's an additional visit, and they may, with a provider that they may not have seen before. Dr. Wolkevich knows most of these patients better. Her providers have multiple IBD patients as well. So that's kind of how we do it. We've been doing this for about 18 months, and I just wanted to go over our UW experience with those patients. So initially we saw 3 patients in a half day, and we had the clinic about every 3 months. We've gotten a little bit faster, and we're doing a little bit less often as there was a big backlog of patients that we moved through, and there are less patients now. But currently we see about 5 patients per half day, and then we're doing the clinic every 6 months. So it's not super labor intensive, it's not super often. It's an important clinic when it occurs. We've seen about 20 patients in that time. So I have data on 13 of those patients, and I only have data on 13 because I wasn't aware that, at least for me, when HealthLink, the visits expire after a year. Like, you can't go back more than a year and see who was in your clinic. So I made a special folder for the transition clinic patients, and I did that for the first clinic visit, and then I missed 2, and then I went back to do it again. So there's about 5 or 6 patients that I don't have, but we'll get that data. So I only have 13 patients. I apologize for that. So 9 are male, 4 are female. Again, going with the national trends, 9 have Crohn's disease, more common than ulcerative colitis. Reviewing the phenotypes of each. Ulcerative colitis, the patients tended to be mild. Again, there are only 4 patients, 1 with only proctitis, 2 with only left-sided disease, so all the way up into the sigmoid colon, 1 with their entire colon involved. None of the patients were on biologics, so no markers of severe disease. 2 were on topical therapy, so kind of mesalamine-based agents. 1 was on mercaptopurine, an immune modulator. 1 was on no medications, hadn't really been on medications for about 3 years, and doing really well. 3 of the 4 transitioned, 3 of the 4 showed up. The 1 who didn't, the 1 who wasn't on any medications. So they'd been feeling well. So they showed up to the transition clinic visit without an adult as well, so they may have some barriers there. But 3 of those 4 patients successfully, easily transitioned over to the adult world. Crohn's disease, more mirroring kind of the national data. 2 with ileal-only disease, 1 with colonic disease, and 2/3 of the patients with more extensive disease, so ileocolonic disease. The phenotypes, again, kind of mirroring the national data, tended to be starting with a mucosal or inflammatory disease, 1 with stricturing, so I'd already had narrowed, had already had surgery, and 3 with fistulizing disease, already have those abnormal communications by the time they're less than 18. So of those 9 patients with Crohn's disease, 7 were on biologic therapy, so our strongest medications, again requiring uninterrupted care. 3 of the 9, a third, had already had surgery. And 8 of those 9 were transitioned. 1 was a big change, time of change for them. They were moving off to college, and there was just too much to kind of transition providers at that point. And they were very attached to their pediatric GI provider. The visit went well, and they'll eventually transition, in the next couple of years. So I wouldn't consider that a failure either. So 11 out of 13 successfully transitioned. We had 1 no-show to the adult clinic. 1 went back to pediatric GI. She'll eventually transition over. Importantly, nobody lost their TNF coverage, so everyone was able to successfully transition from getting their Remicade infusions at the American Family Children's Hospital over to the infusion center, and didn't lose any. Those are dosed every 8 weeks. I thought that was pretty good. We identified two psychiatric diagnoses as well, and those patients are being followed by Dr. Singles. So after we've been doing this clinic, we found a couple of additional barriers as well. So there's always pressure, as I'm sure most of you feel, to kind of see more patients, see patients that need to show up. So my template has a block spot at the end of its clinic for these transition patients, and if it's not filled within 2 weeks, then that's released out. But what I've found is that tends to get released early, get filled. Sometimes we're not able to kind of see those patients, have a clinic spot available exactly when we want it, but we just kind of work it out. There's a time interval. I mentioned we kind of want to see these patients within 6 to 8 weeks from the time we show up in the transition clinic. What we found is that the patients actually kind of want to do it more like 4, 5, 6 months because they're feeling well. A lot of times it tends to be when they're on spring break or over summer and they want to show up at the next break. So there's a little concern that maybe you lose momentum. Maybe eventually they'll have to transition, and that they may miss a couple of visits because they just don't remember or forget. We've had a couple of patients change insurance, so just dealing with those issues. And it's a time where there's a lot of tumultuous family activities. So they're finishing high school, so a lot of times families will move at that time. So getting back to our patients, kind of wrapping things up, our patient, remember, diagnosed with Crohn's disease, looked pretty bad. They actually did really well, so started on chronic therapy with infliximab. Fortunately had a good response, was able to taper quickly off of the steroids, and did really well. We saw them in the transition clinic. They moved over to pediatric world, teleconferenced over to peds, things worked well. They did show up a little late, but that's okay. Sometimes we run behind, but that's common for these adolescents. So just a couple of wrap up. I hope I've shown you that these young patients with chronic disease, specifically focusing on inflammatory bowel disease, but really any patients with chronic disease are at risk of long-term complications if they're left untreated. Our goals of transition are uninterrupted care of these patients, and setting up one of these clinics, there are multiple barriers. It just requires collaboration, cooperation, and good leadership. And that's all I have. I'll take any questions if you have any.
Thanks very much, Ian. I'll ask you to call on the audience and then ask you to just repeat the question for the report.
Sure. Go ahead over here.
Yes, thank you. Interesting concept on the transition clinic. Seemed labor intensive. So two questions. One, would you encourage all of the subspecialties in peds to advance to this model and something for the organization to take on, or is there a even more efficient use of people's time? And number two, the patient is also transitioning in their primary care physician, and was that included in part of the transition thought, so that can also have to be a separate step?
Great question. So the questions are, as part of a global UW Health role, should the PCPs also be transitioned? Is this a goal for all the subspecialties to also transition? So that's a great question. And I think it depends. So getting to the second part first, we didn't include any of the primary care transition. I think that would be a great next step in addition to the clinic. With inflammatory bowel disease patients, we act a little bit more of the PCP than maybe other subspecialties, so we didn't really think about that, or at least I didn't. But I could certainly see where that would be a good next step to kind of add that to the transition process. I think that's a great thought. And globally, a goal for UW Health, some of the clinics are already doing this. Pulmonary does this with their cystic fibrosis patients. And so I think it's an individualized depending on how severe the disease is and whether they could truly do require this uninterrupted care. I think some of the basics of what we've done could be incorporated into all the transition subspecialties. At least tying back, maybe a teleconference back to the pediatric world at the initial adult visit would be a good first step as a goal. Any other questions? That's it.
If there are no other questions, we'll close. I want to thank Dr. Grimes for an excellent grant.
Thank you.